Welcome everyone to our second part of the hearing loss approach lecture. We're gonna continue speaking about the sensorineural hearing loss, which is usually caused by any disease or any issue that is affecting the cochlea or the peripheral nerves or any neural cause leading to a central pathway, auditory central pathway problems. So it's any lesion affecting the cochlea, vestibulocochlear nerve, which is peripheral, or any central auditory pathway disease. Now, we could subdivide the sensorineural hearing loss into congenital and acquired. We're starting with the congenital causes. There are genetic causes. Syndromic, for example, Usher syndrome, Waardenburg syndrome, or non-syndromic, which is the connexin 26 mutation, which is a mutation in the GJB2 gene, or cochlear aplasia, which is no development or an abnormal development of the cochlea. The non-genetic causes could be infections, for example, a congenital CMV or rubella. Prematurity also causes sensorineural hearing loss or any birth complications. Which is the most cause of the sensorineural hearing loss congenital? We could say the connexin 26 mutation gene up until this moment. Now, the acquired causes of sensorineural hearing loss, there are the labyrinthine infection, viral, bacterial, or syphilitic, trauma to the labyrinth or the vestibulocochlear nerve, due to temporal bone fracture or due to surgery. Number 3, noise-induced hearing loss. We could do a lecture later on what are the specific or the approved or the not very dangerous noises that people can be upon for a long time and not affect their hearing. Also ototoxic drugs, so for sure you have to ask the patient about their drugs and their history, especially cisplatin, which is a chemotherapy. So if the patient told you that he or she had treatment for cancer like in any previous time or in their past medical history, you could suspect them having or being under cisplatin. Also aminoglycosides, which is an antibiotic, presbycusis, which is one of the most causes of sensorineural hearing loss, and it's usually a hearing loss due to aging. Meniere's disease, acoustic neuroma, is a very important cause of sensorineural hearing loss, not because it's common, but because we have to exclude it. Sudden sensorineural hearing loss, which is an emergency. Familial progressive hearing loss, and finally systematic disorders causing hearing loss such as diabetes and hypothyroidism. I haven't seen any of these commonly, I mean the last ones. Now, when we're talking about the approach to hearing loss, we could divide it into two parts. If we're dealing with a newborn, it's a way, and if the patient is any other than a newborn, it's another way, because newborns go through screening with specific tools or specific ways for screening. Not that the patient or the newborn came with a problem. We're just screening for hearing loss. Otherwise, any other age, any other patient, we go, of course, through history, examination, hearing assessment, investigation, and treatment. Usually in otolaryngology, there will almost always be something special in the middle. We don't go directly taking history, examination, and then investigation. We usually do something special in the middle. Now, regarding the history taking, of course, you have to introduce yourself to the patient. Ask the patient for the name, for the age, for the gender, presenting complaint, which is usually the name of the complaint according to the patient, plus duration. So for example, if the patient presented with otalgia for 3 days, the presenting complaint would be ear pain for 3 days. But here we're talking about hearing loss, but I just had to give you that example. Now, the history of presenting complaint, systematic review, including recent flu, past history, past medical, past surgical, medications, previous episodes, and immunization is really important. Now, if the patient was a child or a pediatric age, we have to ask about the prenatal, natal, and postnatal, because prenatal the mother could have been exposed to an antibiotic during pregnancy, or she could have had any of the infection that could be transferred congenitally. Natal, to exclude any birth complications. Postnatal, also to make sure that the child or that the patient had not been exposed to any antibiotic. We could know this by asking the mother or the father, did the baby went through any in ICU or any abnormal or not routine things that has been done to him or her postnatally. Now, family history, including consanguinity, which is very common in our country. Now, social history, to know more about the occupation, noise exposure, and finally habits, smoking and alcohol. Of course, this is not exclusive, but this could be covering. If you did this history taking, you're almost covering every aspect important for hearing loss. One of the things important to ask about, I think so now the history of presenting illness, you have to ask about the duration, the onset. Of course, there is a difference between duration and onset. Duration is for how long. The onset is when did it start. Progression, is it progressive very fast or slowly, on and off, or continuous? The site, unilateral or bilateral. If it's unilateral, is it right or left? Is there any discharge? If there is, you have to ask about the color, the smell, watery versus thick. Also, other associated symptoms of the ear, for example, pain, vertigo, tinnitus, or facial twitching. A very important part to be asked, especially if the patient is from the pediatric group, is speech. Have the baby spoken or not yet? If the baby has spoken, how many words? Is it understood or not? And so on. Now, any nasal symptoms, and of course, fever. Regarding the examination, first of all, you have to make sure that the patient is stable, even before vital signs. If the patient is unstable, there is no time to examine. You have to make sure that the ABC are done. If the patient is stable, now we do vital signs. We take the general look, any apparent things that would take us, for example, for a syndrome or something, and then the ear examination. Ear examination can be done with otoscope or microscope. Microscope is better for hands-free examination. Of course, during the examination, we have to do a thorough examination of the external ear, the tympanic membrane, and finally finish it with a tuning fork and do Rene and Weber. The tympanic membrane, as we said, can be seen by the otoscope, microscope, or sometimes rigid scope. It's becoming very common nowadays. The Rene and the Weber, we will do it in another presentation.